Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
All right, so what I'd like to do is spend a little time talking about anemia, and some of the slides I'll tell you in advance have a lot of information. This will obviously be available for you later to go back and look at, but basically I wanted to take you all into the clinic with me today and talk a little bit about the clinical presentation of anemia, how we define anemia, what are the approaches in the diagnosis of anemia, the classifications, and some distinct features of the various anemias that we may see. So anemia technically is a reduction in the concentration of circulating hemoglobin below a level that has been defined as normal for a person, and age and sex do affect what we refer to as the normal levels. Let's make it easy. All the way on the right is what we'll call pseudoanemia. So in this case, the patient has an elevated plasma volume, such as a pregnant woman who has an increased volume of fluid and is artificially diluting her red blood cells. So she's not truly anemic. If you come back to the left part of the slide and you talk about actual or absolute anemia, now we're talking about a decrease in red cell volume. Let's make it simple. What are the reasons somebody could be anemic? Number one, they can't make blood or red cell production is diminished. Number two, they're making blood, but the blood is being destroyed. Or number three, they're losing blood. Why would red cell production be decreased? It could be it could be a number of problems that are acquired or hereditary. Why would red cells be destroyed? It could be mechanical, such as a heart valve. It could be hereditary. And blood loss, I think, is self-evident, such as a bleed from a gastrointestinal bleed. So what are some of the symptoms you might see? One point that I think not only I, but hopefully all who present clinical presentations to you should make very clear is 80 to 90% of your diagnosis is going to be on your history and physical. Your labs, your imaging studies are the other 10%. So in other words, we have to learn to take a good history. And even in the advent of CAT scans and PET scans and other imaging studies, we still need to do physicals. Patients with anemia most commonly present with fatigue and weakness, shortness of breath, and lots of other symptoms, as you can see here, that may or may not present with the various types of anemia. However, if somebody presents to you, I'm tired, I'm weak, I'm short of breath, and you do a little bit more in-depth questioning and you find out that these are more recent symptoms, or how long does it take you to get short of breath? You know, I used to be able to run a mile. Now I walk one flight of stairs. Sometimes they'll get chest pain with it. Other things may happen, such as a woman may have developed very heavy periods and is having blood loss. As part of your history, you may determine that somebody is either vomiting blood or developed bright red stools. So these clues are already there just from the history. your physical exam, they may have a rapid pulse, they may have a low blood pressure, and people can look pale. And all of those are symptoms. There's some more sophisticated symptoms, such as changes in the nails and so forth. But just from the history and physical, it's pretty easy to be suspicious that a patient might be anemic. Okay, and again, I'm trying to go back and forth from the didactic to taking you all into the clinic with me to show you where these symptoms are actually occurring. So we have some normals. Every time we do a complete blood count, or a CBC, as you'll learn the jargon, for males, and these are adult males, whether they're anemic or not is based on the hemoglobin of greater than or less than 13, and for women, it's 12. As we'll get into in a moment, things like MCV, or the size of the red blood cells, MCH, or whether or not the red cells are very red or hypochromic or hyperchromic, help us define the anemia and begin to make a determination of what is causing the anemia. So some of the initial laboratory, as I mentioned, is the complete blood count. Sometimes we get a lot of indication by those indices, the size of the cells and how deeply red or not deeply red, which is the MCH, the mean concentration of hemoglobin. As a hematologist, I'm going to tell you, every time you see a patient that's anemic, you should be looking at the peripheral blood smear. There's a lot of information in the peripheral blood smear, and we'll go into that. So there are lots of ways to classify the anemia. Morphologic, what do the cells look like? Etiologic, why? They're bleeding, they have heavy menses, and based on the reticulocyte count. Reticulocyte count are immature red blood cells that are released from the bone marrow, and they're part of the natural maturation. But when you have a large number of reticulocytes in the peripheral blood, the blood you would draw from a person's vein, it may be an indication that this patient is trying to compensate for anemia, trying to push out from the bone marrow red blood cells. So some classifications of the anemia, whether it's severe or moderate, and obviously this is a little bit of age dependent. It may become more severe at a higher level in an elderly patient, a patient with cardiac or other diseases. So one of those values that we talked about is the MCH. It's one of those numbers that appears on every complete blood count slip. And we're going to show some pictures of that in a moment. And that is the mean corpuscular hemoglobin. In a sense, how deeply red is that cell? And then the other one that we mentioned, the MCV, or mean corpuscular volume, is really the size of the cell. The reticulocytes, and this is a special stain that is done of the peripheral blood to show the reticulocytes. And these are the early red blood cells that are being released. The normal is 2.5% or less. It might be elevated in somebody who has acute blood loss and is trying to compensate. It might be elevated in a patient with hemolytic anemia. So some of the basic approaches to anemia, I'm going to go up one level higher and go back to my history and physical. And definitely part of this should be evaluation of the peripheral blood smear. So there are abnormalities that might affect multiple cell lines from a hematologist standpoint, the red blood, the white blood, the platelet count. And if all three cell lines are involved, something may be happening in the bone marrow, be it a primary problem of the bone marrow or possibly a suppression, such as chemotherapy. If the abnormality is just in the red cell line, the reticulocyte is going to be helpful, whether it's raised, and we might think of acute blood loss or hemolysis or breakdown of red cells. If the reticulocyte count is low, the patient may not be able to make red blood cells such as a deficiency of something that's vital. From a morphologic, what do the cells look like? Microcytic are small cells, and we'll show some pictures. Macrocytic are large red blood cells, and there are anemias where the red cells remain normal. Each of these categories can help begin to fine-tune or get closer to what is the actual diagnosis. So normal red blood cells are felt to be the size of a normal lymphocyte. This is a band, a white blood cell, and these are fairly normal red blood cells, fairly similar in size to this normal lymphocyte that is in this peripheral blood smear. So small cells, smaller than the lymphocyte, so they are microcytic. These cells are also hypochromic, meaning they're not as deeply red. There's only a rim of hemoglobin. Larger cells, larger than the normal small lymphocyte, are exhibited here. And then cells that are pretty normal in size and color, normochromic, normocytic, that's one of the third categories, the third category of anemia that we spoke about. The lower MCVs or the microcytic anemias could be due to something as simple as iron loss. The normochromic or normal size anemias, it depends whether or not the reticulocyte count is elevated, but these could be due to primary bone marrow problems, such as aplastic anemia is a good example. The large red blood cells, MCV, or the macrocytic anemias, classically vitamin B12, folate deficiency, certain medicines, elevated cholesterol, and certain liver diseases, but just to give you a broad outline. So this slide shows several things. These cells are very, very pale. They're hypochromic. These cells are small. They're hypochromic. So this is a hypochromic microcytic anemia, such as one might find in iron deficiency anemia. There's some other interesting shapes in here, such as this cell, which is an elliptocyte, and that may identify a certain type of inherited anemia. So with the microcytic hypochromic anemia, we think of iron deficiency. And if you do a ferritin level, which is a storage of iron detection, and it's low, a patient is iron deficient, and people that are iron deficient can be iron deficient because of bleeding, blood loss, be it acute or chronic, usually more chronic. Women with heavy menstrual periods, people with gastrointestinal bleeding. If the ferritin level is normal, yet it's a hyperchromic anemia, it could be something such as thalassemia, which forms smaller red blood cells, or even what's called anemia of chronic disease, such as chronic inflammation. So iron deficiency anemia. When we see iron deficiency anemia or diagnose iron deficiency anemia, then we sort of go back to who is the patient we're dealing with. Is this a young, actively menstruating female who might be losing blood in her menses? Is it a 70-year-old man who's coming in with either GI gastrointestinal bleeding? You might be dealing with a gastrointestinal malignancy. So diagnosing the type of anemia may be leading you very often to an underlying diagnosis. As I mentioned before, a few moments ago, thalassemia. This is a red blood cell that shows targeted red blood cells. And this is something, when you see many of them, it makes you immediately think of thalassemia. There are types of thalassemias, alpha and beta, globin, and this is something that's diagnosed by something called a hemoglobin electrophoresis. The etiologic classifications of anemia, we've sort of touched on a little bit. What is the underlying cause due to the deficiencies, iron deficiencies? Now, even megablastic anemias can be looked at as an etiologic anemia, such as a decrease in folate or B12. You can have anemia of chronic diseases, of liver disease, and so forth. But I just wanted to show you there are many ways to look at anemias. Macrocytic anemias are red blood cells that are larger than a normal small lymphocyte. It's another little clue in this slide. This is a polymorphonuclear leukocyte, but it has too many segments. So looking at this, one might think of possibly a deficiency in vitamin B12, folate, certain medications, certainly chemotherapy could be one. So when we see a macrocytic anemia, we want to know, are you making a lot of young red blood cells, the reticulocyte count we talked about before, or are the reticulocytes normal or low? If the reticulocyte count is increased, it's very possible you're dealing with a hemolytic anemia and or a destructive anemia, and the reticulocyte count is elevated because it's trying to compensate. On the other hand, if the reticulocyte count is normal or low, it may be a different type of problem, such as drugs, particularly chemotherapy, hypothyroidism, which has something to do with the way cholesterol is deposited. Some next steps may involve a bone marrow exam, certainly checking the B12 and folate, but obviously taking a history and finding out what medications the patient is on. Are they a drinker, and so forth, because that has a lot of effect. So a macrocytic anemia, just another way of looking at it. And what I wanted to, the reason to show this slide is to show that starting from our simple way of looking at anemias, we can get to the more complicated, more sophisticated anemias, such as deficiencies of certain enzymes, B12, folate, medication, and even and occasionally hemolysis or destruction of red blood cells, which we'll talk about in a moment. So megaloblastic anemias can be severe, they can be mild. If somebody is developing iron deficiency or B12 deficiency, depending on the point in time at which you see them, the anemia may or may not be as severe. That comment is also goes along for the other causes, how long they've been on a therapy that may be causing the problem. Wanted to show a couple of morphologic slides, or what the slides or what the cells look like. The big cells, the macrocytes, some destructive anemias leave parts of cells embedded or Hal-Jolly bodies. Sometimes this happens in a patient that's had a spleen removed. A teardrop cell could be from a lot of reasons. It could be from somebody who's had their spleen removed. A schistocyte is a cell that's been sheared. It could be mechanical. It could be such as an aortic valve replacement. It could be due to kidney disease. This is a nucleated red blood cell, which the bone marrow has extruded into the peripheral blood. It doesn't belong there in the normal circulation. The bone marrow is working overtime to correct the problem. As I alluded to above, normally a polymorphonuclear leukocyte or segmented neutrophil should have 3 lobes. This one has way too many lobes, and that would make me think of a macrocytic anemia, particularly B12 folate, when you see that picture. So there are ways of, there are blood tests, that can be done to actually check folate and B12 levels. There are different ways people can become deficient in B12. There's something called intrinsic factor, which binds the B12, and the Schilling test is helping us determine that. Patients that are B12 deficient have what's known as pernicious anemia. Some of the other more sophisticated tests are antiparietal cell antibodies. And one of the other things with these type of anemias is it can involve multiple cell lines, not just the red blood cells. So hemolytic anemias are destructive anemias, And as I mentioned a little while ago, they can be mechanical. Somebody who's had a valve replacement or had other devices implanted. It may be immunologic, and it could be, for example, drug-induced. For example, penicillin can cause a hemolytic anemia. It also can be certain enzyme deficiencies, such as G6PD or glucose 6-phosphate dehydrogenase deficiency, a membrane problem. Certain anemias with changes in the hemoglobin change the configuration of the cell. For example, sickle cell anemia creates what are called irreversibly sickled cells, and they have difficulty navigating the blood vessels, and they shear, they break, and that's another form of hemolysis. And I mentioned the immune and the mechanical. So normally in these types of anemias, you very frequently will see an elevated reticulocyte count, which is this smear. You'll see fragmented cells, cells of funny shape, little pieces of cells, and cells of very varying shape. So again, sort of thinking about how do you think about these anemia? Sometimes there's some specific types of fragmented cells that we see. It's sometimes, if you're suspicious that it's immunologic or due to a medication, you'll do a Coombs test, which is looking for antigen antibody deposition on the surface of the cell. Just another example of the smear. So the immune hemolytic anemias, these are interesting because they can be primary. In other words, people are destroying their red blood cells as their only problem. Or an immune hemolytic anemia may be part of another problem, such as somebody with a lymphoma. Sometimes patients with rheumatoid arthritis will present with immune hemolytic anemias or other lymphomas as well. The Coombs test, as I mentioned a moment ago, is detecting whether or not there's antibody on the surface of the red blood cell to help determine if this is an immune related anemia. The sickle cell anemia is an abnormality in the hemoglobin. It's a replacement in the sixth place of the beta chain. This is a artist's conception of a irreversible sickled cell as opposed to the standard bicave red blood cell. These are anemias that are both hemolytic and they can be aplastic, meaning that sometimes a sickle cell patient can shut down bone marrow production of all three cell lines: red blood, white blood, and platelet. But most often you see them as moderate to severe anemic patients. And if you look at their peripheral blood, you very frequently, if they have hemoglobin SS, you'll see lots and lots of the irreversibly sickled cell. If they have if they have sickle trait, which means from one parent they have hemoglobin S and the other they have normal or hemoglobin A, you'll see a mixture of cells. There is a simple test called a sickling test, which helps diagnose, but we really do a hemoglobin electrophoresis, a little bit more sophisticated test. And as I mentioned before, starting from simple ways of looking at anemias and getting a little bit more sophisticated, talking about G6P deficiency, it's a hemolytic anemia, the reticulocyte count is high. And the only point to put this slide in here is just to show you that as you go through basics steps, you can ultimately come to a very sophisticated diagnosis, be it G6P deficiency or HS or hereditary spherocytosis. This is another type of anemia where you have very small hyperchromic red cells. You'll see other types of fragments in these patients, and there's some specific tests that we do in osmotic fragility. Normally, when you see a number of cells that look like this, you might be suspicious you're dealing with hereditary spherocytosis. So remember, we talked about the normochromic normocytic anemias. This patient is anemic, but their red blood cells look normal. So in this case, morphology isn't helping. This could be a cancer patient. This could be somebody with chronic renal disease, somebody with a chronic inflammatory disease. And these sometimes can be a little bit more challenging. And this is the anemia of chronic disease. There's some more sophisticated tests that we can use to try to help determine the etiology, such as the erythropoietin level, for example, and that would be something that you might consider drawing in a patient with renal insufficiency, kidney failure, because that might have therapeutic implications of using an erythropoietin type compound to try to stimulate the bone marrow to make red blood cells. These anemias are somewhat not easily diagnosed because they can have decreased serum iron, decreased total iron binding capacity. They may not look classically like an iron deficient anemia. If they have an increased marrow storage of iron, then they have what's known as ineffective erythropoiesis. They've got the iron, but they can't use it. So it builds up in the bone marrow. And there's a stain that we do of the bone marrow where we assess the iron stores. Aplastic anemia is an anemia that involves all three cell lines, or pancytopenia. The red blood, the white blood, and the platelets are decreased. And aplastic anemia is something that can be very severe, that almost always requires a bone marrow to determine. There can be some inherited related ones, particularly Fanconi's anemia is one. And sorry, went the wrong way. So some summary terms are the microcytic hyperchromic classic iron deficiency anemia, the macrocytic hyperchromic or megaloblastic anemias, such as vitamin B12, folate deficiency, certain chemotherapies that interfere with production. Not only do they interfere with the production of cells in the red cells, some of those chemotherapies may be the reason people develop hair loss for the same mechanism. The normochromic normocytic anemias, some may be hemolytic, some may be due to chronic disease. Pancytopenia, all three cell lines are involved. Just sort of a couple summary slides, talk a little bit about the lab tests, and I'll leave this for you to look at your leisure. And to get back to sort of starting from scratch, are the cells big? Are the cells small? Do the cells have a lot of hemoglobin? Do the cells not have a lot of hemoglobin? And those simple initial characteristics, if you will, of putting the branches on the tree to make it simple, allow you to get very sophisticated and put the leaves on the branches of the tree and get all the way down to membrane and enzyme deficiencies and various deficiencies. So I just wanted to leave you with the thought that although anemia is very common, sometimes it can be complicated. If you look at anemia in fairly simplistic terms, is the patient making blood or are they not making blood? If they're making blood, are they losing blood? Is the blood being destroyed? If they're not making blood, why are they not making blood? Is there a problem in the bone marrow or is there a deficiency? So I think if you think of this in simplistic terms, it helps you begin to figure out even the most complicated of anemias. Final comment I would make is as a hematologist, when you see an anemic patient, look at the peripheral blood smear. There's a lot of information in there.